Hello and welcome to Making the Round, a podcast by the American Medical Association. Today's episode is part of our Health IT series from the AMA-MSS Committee on Health Information and Technology. My name is Christopher Jackson and I am a medical student at the University of Toledo, College of Medicine, and I'll be your host for today. Today we are joined by Dr. Shipra Arya, an Associate Professor of Surgery at Stanford and leader in frailty research. Thank you for being with us, Dr. Arya.
Thank you for having me.
So just to start us off, could you give us an idea of how you're involved in the health IT space and what you're currently working on?
Sure. I think in the health IT space is so broad, and my major focus right now is on telehealth services for surgical patients, especially vascular surgery patients,
Okay.
and how we can improve access to care for patients who are living, far away from healthcare centers, especially in the time of crisis such as COVID. It has really brought telehealth to the forefront, and trying to, meet patients where they are. That's been most of the focus of my work as, section chief at the Palo Alto VA for vascular surgery, as well as, applying some of the principles of the frailty work that I'm doing.
Okay, and what would you say is the impact of your work, and have you had any challenges while you're trying to get this work completed?
Yeah, definitely. We've learned a lot, especially through the COVID pandemic. How telehealth, it depends not just on resources and technology that you have, but also, the abilities of your patient population, their comfort with the use of technology, and how do you make it more accessible to patients of all age groups, of all backgrounds, and people with disabilities. That's a major part of our patient population, and to make sure that our push towards telehealth or push towards technology-based care doesn't exclude patients, because that even further worsens, the access available to some of our patient population.
And you just touched on this a little bit. Could you delve a little bit deeper into how COVID has impacted your work and the
Sure.
changes you're seeing in the hospital?
Yeah, as a surgeon, it was unthinkable prior to COVID that we would actually provide telehealth services. Most of our patients, we would see them in person, we would do our preoperative assessments and even our postoperative visits in person. But COVID has forced us to rethink that, do we really need face-to-face visits even for a surgical patient population? And what are the gaps? What are the specific points of time in their care that we can actually apply telehealth, to their care. So with COVID, we moved a lot of our initial consultation and triage services, and are continuing to do so in a very rapid fashion into a telehealth format, especially for vascular surgery patient population. A lot of them have diseases that could be managed medically, and the first point of interaction with a surgeon is that whether they need surgery or not, or whether there's something we could do non-surgically to actually optimize their health status, improve their quality of life, and try a conservative approach first before we move on to an interventional approach. So that, has been, in my mind, a big focus for our patient population. That, how do we better select patients who you could, offer surgery to and would meet their needs, rather than patients who, could possibly benefit from just a conservative approach first. So that was sort of the first point of triage or intervention that we identified. And then a number of our post-operative patients, they are, on a chronic surveillance regimen, because vascular disease is a chronic disease. Patients who have abdominal aortic aneurysms, patients who have peripheral artery disease, who have cerebrovascular atherosclerotic disease, who have venous disease, they need surveillance to make sure, A, the patency of their interventions is robust, B, if there's any change, do they need further interventions, and C, is there, medical management in terms of their medications that they're supposed to be on, are they optimized? Does that need to be changed? And is that what's driving their, change in their health status? So all of that we find that actually could be accomplished with telehealth, because the face-to-face visit is, is of great benefit for patients who have wounds, who have incisions, who have, things that we need to evaluate from a physical exam standpoint. But a lot of our surveillance protocols rely on imaging, and imaging doesn't necessarily have to be done on the same day that the patient is here. So we've moved our surveillance protocols to fit the needs of the patient, that they go get their imaging done, their vascular lab studies, non-invasive studies, or their CAT scans done ahead of our visits, and then we just do a video visit or a phone visit to kind of follow up on the results, discuss their symptoms, discuss how they're doing, and then at each point there's an assessment that would the patient prefer to come in and see us if there's been a change in their health status. But that saves the patient a visit. We are actually interacting with them in a space that they feel comfortable with. I actually really enjoy our telehealth focus now, because a lot of the patients, especially our veterans, they live far away, and to avoid them having to drive into the Bay Area and see us, it's actually, they enjoy it, we enjoy it. We get to see some of their family members, their pets on the screen, their own familiar surroundings. So I think in my mind it's more patient centered on all fronts.
I think anything anyone can do to avoid driving into the Bay Area is a good thing. Uh, okay, our next question. I know you and Dr. Olami, you do a lot of work in mobile health, but what do you think the future of mobile health looks like? And what are the major pros and cons
Yeah,
that you think
that's
come
a
with
great
that?
question. And my collaboration with Dr. Alami has, in fact, educated me and informed me about mobile health applications, because he's the director of the Biodesign Mobile Health Technology Platform and Services. Um, I think there's a lot more to be done in the mobile health space. Beyond telehealth, we need to be able to monitor patients remotely. We need to be able to see, how their self-reported symptoms actually corroborate with their actual function and quality of life, which directly ties into some of the work that I'm doing in terms of frailty, especially frailty in the peripheral artery disease population. Um, because a lot of frailty phenotype is driven by their function, their ability to carry out their activities of daily living and instrumental activities. And those sort of things self-report is one way of capturing it, but we don't know if we start monitoring these patients in a remote health setting, we find that their self-reported function is actually very different than what their actual function is. And patients, especially with cognitive impairment or dementia, in their cases, we are relying on caregivers to provide some of this information. And if we could monitor them in a way that could tell us a true measure of the function and the impact some of the chronic conditions are having on their day-to-day life, that could be game changing. So I do think there's a lot of possibility for function and mobility monitoring remotely. And it also could help us guide, early interventions. Patients, right now we have protocolized interventions, right? We see patients back at a specific time point. It's not necessarily driven by a change in the patient's health status. It's driven by clinical protocols of, okay, this is where we anticipate the change would happen at 6 months or a year. But if there was a way to identify early decline, early changes, and intervene, at a critical time point, which could make a difference between a patient, keeping their bypass open versus moving on to an amputation, that could be a very significant difference for a patient's life.
And as a future physician, where do you see the health IT space going in 10 to 15 years when I'll be practicing?
So I think a lot of patient generated data, I think that's going to be driving a lot of our clinical decisions. I mean, we're already seeing some rudimentary ways where that is helpful, where patients upload their pictures of like wounds or things that they want addressed, changes in sort of their health status. But the patient generated data piece is going to change dramatically, because the patients we are going to be serving are going to be facile with the use of mobile health technologies, would want to use more of that and avoid unnecessary health visits, and probably be more, um, you know, uh, they would want healthcare to be delivered at their point of care rather than our in the hospital setting. So I think all of that is going to drive health IT space a lot. The ability of patients to generate sort of patient generated health data to actually encompass mobility, encompass vitals, blood pressures, heart rates. If we could monitor patients where they are, whether it is through continuous monitoring or through a setup that we send out to them and they, put it on, generate their health data, and send that back to us. I think all of those things are going to change health IT space a lot. We're already seeing, patients who can be monitored with sort of a Ziopatch based setup where instead of a patient having to come in and wear a monitor for monitoring their, abnormal heart rhythm, like a heart rate, now we just send out a device to them which they can, tack onto their body for 2 weeks and then send that back to us, and we can remotely capture that data. Or people are using the, something like a Apple Watch to monitor for, changes in their rhythm. So those sort of, healthcare data generation and then feedback loop into the healthcare system and the electronic medical record is where things are going to, eventually move to, is what I see.
Okay, and we talked about this a little bit earlier, but there's been a lot of changes, obviously, because of COVID, and some of those are going to stick and some of those aren't. Which ones do you think are going to have the staying power?
I think the staying power is always with, things that drive payment and policies. I think as consumers, if they would see that there's a better way of, getting their healthcare in a remotely without having to make the visits, being able to do telehealth visits, being able to generate this healthcare data and be monitored remotely. And if that's what the consumers, that is the patients, that's what they want, then that is what's going to drive change. So, there's still going to be the need for, interventions to be performed on site, certain visits and complete assessments to be performed on site. But the lasting change I see is going to be for things that the patients demand and the consumers want. So, we'll see what that holds in the future.
So, Dr. Arya, our last question today is: how is frailty research and frailty going to be affected by health IT in the future, and what do you see as the pros and cons?
Definitely. I think frailty research has a lot of potential for health IT research because measurement of frailty relies on, movement and mobility and strength. And all those measures, they don't have to be captured in person. They are things that we could do to sort of capture mobility and, walking speed and grip strength and these sort of things where the patients are at. We can also monitor patients more effectively, patients who are higher risk. If they are at a higher risk for readmissions, higher risk for complications, a remote patient monitoring could be very useful. If we do interventions on these frail patients, their postoperative monitoring could definitely change and have a different phenotype compared to what robust patients and more mobile patients have. So I think there is opportunities not only in the preoperative assessment phase, in the shared decision-making phase, that whether this is the right approach for the patients from a surgical. I'm talking about a surgical standpoint. I think interventions for frail patients from a medical standpoint would be different. There is opportunities for prehabilitation. Could we do remote home-based prehab, which includes some exercise regimens, nutritional monitoring, and getting them ready for intervention so that they could have the best possible outcomes. We have seen some home-based exercise programs work really well for cardiopulmonary-based rehab. So patients who undergo coronary or peripheral interventions, we've actually shown from Palo Alto VA some work done by Dr. Myers and their home-based exercise rehabilitation program that we can effectively achieve the same outcomes for patients, which could be done in inpatient rehabilitation. So that certainly carries a lot of promise for the frail patient population. Could we do prehabilitation as well as postoperative rehabilitation remotely in a home-based setting? And then finally, the postoperative monitoring and identifying points of intervention for these patients to avoid readmissions, to avoid major complications, and to avoid major declines in functional status or health status. So that remote patient-based monitoring has potential. So all of these things are right now a little bit pie in the sky, but we know that it's feasible based on all the work that has been done so far. So I think that's where the space within frailty management and geriatric surgery is going to move to in the future. with the help of advancement in health technology.
Okay. And finally, where can people at home follow your work if they're interested in frailty research or anything that you discussed today?
Sure. So I post a lot of my work on Twitter as well as our university website. All of my publications are available on PubMed as well as other research outlets. It's I don't have a web page as such, but I'm happy to connect to people in person if they would like to collaborate. Or I mentor a number of students remotely as well, because this is such a burgeoning field and a lot of scope for involvement from a patient clinician interaction standpoint, from a health IT standpoint, from an outcomes and policy implication standpoint, and also from a rehabilitation and health system based intervention standpoint.
Okay. Thank you very much. Well, everyone, that's all for today. Thank you for listening, and thank you for your time today, Dr. Arya. This has been Making the Rounds, a podcast by the American Medical Association. You can subscribe to Making the Rounds and other great AMA podcasts wherever you listen to yours, or visit ama-assn.org/podcast. Thank you for listening, and goodbye.